Hey guys, welcome to Musculoskeletal Part 4 and your last part. And this is maybe our last med-surg lecture together. I know Miss Rojas has some cardiology lectures with you, but this is my last med-surg topic. And after this, we're going to go into PVR, which is very different and very fun. So let's begin here by talking about osteomyelitis. And in your book, this is on page 743, okay? So if you are listening in your car or whatever, and you don't have your PowerPoint in front of you, please go back and pull it out later, because as I talk, I am going to add some things that you need to study for your test. You know, I do that all the time. I want you to make a good grade on your test. I want you to do well on your NCLEX, so I always point out things to you that may be on your test or maybe on your NCLEX, right? Okay, osteomyelitis is a bacterial infection of the bone, sudden onset with severe pain, marked tenderness at the site of the infection, fever and chills, swelling of adjacent soft tissue, headache, and malaise. You can have an increased white blood cell count, increased sedimentation rate. One of the most important things in prevention of osteomyelitis is good hand washing. So if you're caring for someone who has an injury, obviously you're going to wash your hands or sanitize your hands before taking care of them, but this is a good way to prevent this. And make sure if you're doing a sterile dressing change that you're using good sterile technique. All right. Okay. Going on to say your PowerPoint, I'm on page 10 of your PowerPoint at the top. The earlier osteomyelitis is diagnosed and treated, the better the prognosis. The history of injury to the part, open fracture, boils, furuncles, or other infections is what causes it. And a furuncle is a hair follicle that has become infected. All right, a bone biopsy can diagnose this. Also, a x-ray can diagnose it as well. And like we said, the person is going to have possibly fever and chills as well. They're going to be prescribed antibiotics for treatment for 4 to 6 weeks. They may have an abscess that needs to be incised and drained, so they may cut a window in the cast to be able to treat that. Dead bone and debris are debrided from the site, and the affected limb is immobilized for complete rest. And as a last resort, amputation could be the only cure. I personally have not known anyone that's happened to, but that's what it says here. Okay, as far as non-union of fractures, just know that electrical both groan stimulating devices can be used. These patients will see a specialist for this type of therapy, and possible surgery and bone grafting is all you need to know about that. Okay, fat embolism. You will see a question on your test about fat embolism, probably also on your NCLEX. All right, so signs and symptoms of a fat embolism. This is in the middle also of page 743. And signs and symptoms of the fat embolism. It says change in mental status, respiratory distress, tachypnea, crackles and wheezes on auscultating the lungs, rapid pulse, fever, and petechia, which is a fine red rash over the chest, neck, upper arms, or abdomen. So all of those are symptoms. If you do see any of this occurring and you have a patient who has had a fracture to a long bone, remember we said that is your humerus, possibly the femur, and the leg, those are long bones. So particularly if they've had that kind of injury. Unfortunately, I knew a lady about my age who had an ankle surgery for a fractured ankle, and she developed a fat embolism and passed away. That was years ago when I was about 25 years old, and she was my boss, and she was about 55 years old. And she passed away from that. And her symptom was shortness of breath initially. So if you have an NCLEX question about a patient who has had an injury to a long bone, and they're underneath your care and they start having respiratory distress, restlessness, the petechial rash on the chest, then you need to call the rapid response team. Also get the patient's MD on the line and tell them you're concerned that there may be a fat embolism where fat has occluded a blood vessel. The patient needs to be placed in high Fowler's position. There's an 80% mortality rate with this. So just like I said with my old boss, that was a long time ago, she passed away, so 80% mortality. Crash cart needs to come into the room. They're possibly going to need to be intubated. And it is rare, though. I did place that on my notes. So post-operatively with your patient who has had a repair or a reduction of a long bone is making sure that they are getting plenty of fluids, maintaining their IV during doing your neuro checks, and early post-op care, whatever the surgeon orders about movement or anything like that, making sure you're going by the orders there. But it may be that they have to maintain immobilization at first, which puts them at risk for this fat embolism happening. Anything else with that? Let's see, I think we covered that. Okay, DVT yesterday. We talked about DVT quite a bit, so just wanted to add, we didn't mention about compression stockings or sequential hose. TED hose, you've probably seen this more recently than me since you've been in the hospital setting. I do see these being used sometimes, but more so I saw what's called sequential hose, which are Velcro plastic wraps that are put on people's lower legs, and they're connected to a pump by electricity, and it really just puts some pressure on the lower extremities to get the blood flow back to the heart. And those are very important for someone who has had a surgery like abdominal surgery or something like that. But it really is just, at the surgeon's discretion if they're going to be used on the lower extremities. Range of motion exercises could be important as well. Anytime someone's immobile, those become important. And I made a note on here, if someone is taking a blood thinning medication like Xarelto or Eliquis, those are quick acting and they can be expensive. So if someone's taking Eliquis, for example, and they're picking up their medication and they paid, whatever they paid. Maybe they've got some insurance, maybe they don't. But let's say they paid $300 for that. They unfortunately need to be taught that they can't make that last and just take it every other day or something like that. It's a medication that needs to be taken every day because it is quick acting and it's only protecting them for the period of time, the 24 hours after they took the pill. Some people take it twice a day, but it's only protecting them for a certain period of time. All right, so if you're taking care, something else I wanted to point out, taking care of this patient who had a long bone injury or surgery for reduction of a fracture, if their pain medication is not relieving their pain, that's something that needs to be reported also. It could mean that they have, well, maybe not an embolism, more so associated with compartment syndrome, which is your next slide there. Compartment syndrome is really when the swelling has nowhere to go. So it does cause the patient to have a great deal of pain. You can see this with a knee surgery, bone biopsy, leg biopsy, leg or arm surgery. So compartment syndrome, I'm at the top of PowerPoint, page 11. It is when the external or internal pressure that restricts circulation in one or more muscle compartments of the extremities is happening. It's a severe, unrelenting pain unrelieved by narcotics. So after surgery, placement of a cast, even after an amputation, the part needs to be elevated. You know you're going to go by the doctor's orders, but usually it's going to need to be elevated. Dressings do not need to be too tight. You're watching for edema during doing your neuro checks, and watching out for pressure on adjacent tissues. So if this compartment syndrome happens, there's pressure on tissues, pressures on blood vessels, decreased blood flow, and necrosis or death to the tissue, and that's what causes the problem. I mentioned yesterday when we were talking a little bit about this, and I knew of a young lady who lost her lower leg because of that. It was a sentinel event that's caused. It was a big deal, and the hospital I worked for back in the day, and it ended up changing some policies and a lot of hospital teaching about compartment syndrome because she presented to the ER, unfortunately, after her surgery 2 times with unrelenting pain, and it wasn't addressed enough, so she ended up losing her lower leg. Okay, you have a picture at the top of page 744 that talks about doing the surgical fasciotomy, this linear incision down the fascia to relieve the pressure on the nerves and blood vessels for the compartment syndrome. And sometimes, unfortunately, it has to stay open for a while in order for it to heal. Okay, so that's all we'll say about that. All right. Okay, let's move over to talking about nursing management of fractures. Okay, I think we talked a lot about the mechanism of injury yesterday. Physical assessment. So you're going to compare extremities. We talked about that yesterday. If you're concerned and looking at the right arm, then you're going to compare the left arm. Same thing with the legs. Comparing pulses. Comparing your assessment, comparing edema is important, looking for misalignment. Doing your neuro checks, very important. Checking for capillary refill, temperature of the fingers or toes. And also, I didn't mention yesterday, it's not right here on your PowerPoint, but if someone has bone that is healing, whether they've had a open reduction, closed reduction, have a cast on, whatever, protein is important, especially for our older individuals to get in enough protein. So they may need to add protein drink supplement into their diet if they're not doing that and you're concerned about the level of protein that they're getting in. We talked about cast care yesterday, so I'm not going to add that in. Okay. I did want to add in arthralgia is a term for joint pain, and paresthesia is a term for tingling. Okay, now let's move on into some inflammatory disorders of the musculoskeletal system, Lyme disease, osteoarthritis, rheumatoid arthritis, gout, and Paget's disease, I think is the way you describe that or say that. Okay, Lyme disease is caused by the deer tick. It is systemic, causes flu-like symptoms, joint pain. It can actually cause a lot of different symptoms and chronic complications. So if a patient reports pain and stiffness in the joints and muscles, they can even have other systems involved, also vague symptoms that they don't know what's happening to them, even the cognitive difficulties that can be associated with Lyme disease as well. Long-term treatment for some of these people, there's different treatments going on for this, but really just remember that it is a systemic disease. It can cause a lot of chronic complications, and people need to use repellents if they're going to be outdoors to prevent that. We've talked about osteoarthritis quite a bit also. Wanted to just reemphasize it's a degenerative joint disease. It is common. It's a cartilage breakdown. For some unknown reason, some people produce less cartilage than others. Weight reduction is helpful as well. I'm sorry, we have not covered osteoarthritis. I was thinking we talked about that yesterday. We did not. We talked about osteoporosis yesterday, but we didn't talk about osteoarthritis. Okay, so osteoarthritis, you have a chart on page 749 that looks at the differences in osteoarthritis and rheumatoid arthritis. So be sure and look at that chart, because when you're talking about osteoarthritis, you think more so of someone who is in their maybe 40 years old or older. It talks about that in this chart here. 40, 50, 60 years old. It is associated with obesity, and it can be unilateral, which means they can have osteoarthritis in the right knee but not have it in the left knee. Where rheumatoid arthritis, it is going to be in both sides of the body, typically. There is juvenile rheumatoid arthritis also, so even a young person can have rheumatoid arthritis, but you think more so of your older person, 40 or older, so to speak, 50, 60 with osteoarthritis. Healthy People 2020, there are some goals related to arthritis. And like I said, it can occur asymmetrically, affecting 1 to 2 joints, and that's it. And they will feel achy and stiff in the morning time. Okay, just a second here. I think I had some more notes about that. There is no real cure for osteoarthritis. The focus is on pain control. A diagnostic test for it can be X-ray, CT scan, MRI. Medication, of course, the first line is NSAIDs in treating this. Heat and cold therapy, weight control, imagery, acupuncture, acupressure, and sometimes total joint replacement does have to happen. Okay. Your book talks about making sure your patients do not exceed, if they're taking acetaminophen for osteoarthritis, 3,000 milligrams per day. They want to limit it to not over that or less if they can. And remember, if someone is taking a blood thinner, then NSAIDs are a no-no. So they cannot take a Advil if they're also taking something like Eliquis or any kind of a blood thinner, actually. They need to, with osteoarthritis, balance exercise and rest. Moist heat applications can be beneficial, and encourage them to maintain weight within the normal limits. Okay, rheumatoid arthritis. It is an inflammatory disease of joints. Some diagnostic tests, as far as blood tests, can be the rheumatoid factor, sedimentation rate, C-reactive protein for rheumatoid arthritis, anti-nuclear antibody. Those can be some blood serum test for rheumatoid arthritis. This PowerPoint in the middle of page 13 talks about that they can have remissions and exacerbations. So they can have some periods of time where they're doing really well, and then they'll have a flare-up of their rheumatoid arthritis. They can have a condition called pannus, which is granulation tissue that destroys cartilage. It limits the nutrition that can be able to get to the good, healthy cartilage and cause damage. They can also have nodules in the pleura, heart valves, or even the eyes. Rheumatoid arthritis is an autoimmune disorder. It is more prevalent in women. The cause is unknown, and there are genetic factors associated with it. One of the number one symptoms of rheumatoid arthritis is fatigue. Joint pain, warm joints, edema can cause limitation of motion, of course, multiple joint symptoms, and it is symmetrical. So it affects joints on both sides, can affect joints of the hands, wrists, and feet, and limit greatly activities of daily living. So remember, you have your chart. I would look through that very well on the bottom of page 749 that compares osteoarthritis and rheumatoid arthritis. As far as rheumatoid arthritis, also adding morning joint stiffness that can last more than 1 hour, or arthritis pain in 3 or more joints that lasts for 6 weeks. Okay. As far as other medications, we mentioned the NSAIDs for rheumatoid arthritis, but we do want to relieve pain, minimize joint destruction, promote joint function, and preserve ability to perform self-care. So other medications are salicylates, corticosteroids, antimalarial drugs, methotrexate, gold compounds, that's an older therapy, sulfa-D-penicillamine, and the DMARDs, which are disease-modifying anti-rheumatic drugs. I'll mention more about PHARM for musculoskeletal at the end of this section. Tumor necrosis factor drugs can be used, systemic corticosteroids also. As far as someone who is taking an NSAID for arthritis, they need to have their liver function monitored, kidney function, central nervous system function assessed frequently, watch for signs of blood dyscrasias or blood disorders, check for tinnitus or hearing loss. We went over that in our sensory chapter. And the side effects of NSAIDs can be serious and sometimes permanent. Of course, they can have bleeding abnormalities also. If early signs of toxicity appear, they should be reported promptly to the physician. So teach your older patients, I'm on the bottom of page 14 with your PowerPoint, taught to watch for side effects. So watch for loss of hearing, ringing in the ears, excessive bruising, bleeding when they're brushing their teeth, feeling greatly fatigued. If they're on drug therapy, they may feel fatigued, obviously, anyway, but that could be a sign of toxicity also. Dizziness predisposes to falls. They can occur with analgesics for arthritis, pain, particularly if the medication contains codeine. So making sure that you're looking around at their environment and trying to make it safe as possible. Remember, safety is always a big issue when answering test questions. Advise patients to arise slowly, hold on to furniture until steady, and wait until the dizziness passes before trying to walk. Anytime you're dealing with an older patient, try to talk to them about rising up slowly from a chair and don't just take off. Sometimes it feels better to their joints to try to move quickly. They may not be able to do that. I've seen this happen plenty of times in older people, that they are sitting in a chair and they just get up and take off and then they fall. So teach them about rising slowly. Make sure they have their assisted devices close by. Okay, orthopedic devices. We've talked about that somewhat as far as braces, splints, cast. Just some definitions here. Synovectomy disrupts inflammation. It can be a treatment with removing some fluid from around a joint is what that is. Osteotomy is removing a piece of bone to restore function. They can have tendon reconstruction or arthroplasty, and it can be a total joint replacement, such as a total knee replacement or total hip replacement to relieve chronic pain. You have probably had relatives who have had this done. I have too, and have helped take care of them. And you know that just for a few hours they're immobile after that surgery, but then their physical therapy comes in and has them up and around and moving. And some with knee replacements go home in the evening after their surgery. And a few days later, they will actually start physical therapy, and they may even come into the room and have them weight bearing that day after the surgery. They at least have to move around and get up by the bed to prevent what? Of course, DVT. So standing on the operative day can be very important. Total hip replacement discharge teaching. This is on the top of page 15. And I wrote a statement that I wanted you to hear. Okay. Prevention of dislocation is a major nursing responsibility. Prevention of dislocation is a major nursing responsibility with your total hip replacements. So you have a picture at the top of page 752 that shows this wedge pillow between someone's leg who's had a total hip replacement. And that is to keep the legs, keep the hips abducted, okay? So when you think of the word abduction, you think of someone being abducted or taken away. So just like in this picture, the legs are being taken away from the midline, so that's abducted. It's hard for me to remember those. Sometimes I remember that being hard. So even if you think about your arms being taken away from the body, legs, think of abducting. When you think of the word adducting, ADD, then you're bringing them together or adding them, bringing them back together. Okay, so that's the difference in abduction and adduction. So the abductor pillow, that's called, or abductor wedge, can be used. And as far as other teaching, off the top of page 15 in your PowerPoint, it is okay to lie on the operated side. For 3 months, the patient should not cross their legs. Putting a pillow between the legs when rolling over or lying on their side in bed. So that's something important to teach the patient when they're going home. It's okay to bend your hip, but not beyond a right angle or 90-degree angle. So that means, like, if they're sitting in a chair and it's a 90-degree angle, that's probably fine. But if it's a chair that is a cushy chair that causes their bottom to be lower than their knees, they do not need to do that. So avoid sitting in low chairs and continue their daily exercise program at home. DVT prevention, very important. Physical therapy is very important, and doing their surgeon recommended mobility is important. So most of these patients, when they leave the hospital, they're going to have a case manager that's going to call them from the hospital that's going to ask, did you make your follow-up appointment? Are you taking your antibiotics? Are you taking your blood thinners if that's prescribed? Are you following your instructions that the surgeon gave you as far as movement? That's very important, and reminding them you're not supposed to cross your legs. Sitting at a 90-degree angle is very important, and things like that. So, okay, knee replacement, they also need to be watching for DVT prevention, looking at the legs, making sure there's not redness, swelling, heat in one of the lower extremities or the operative lower extremity as well. And always they're watching for fever, both of these patients at home, to make sure they're not getting an infection. Okay. Management of rheumatoid arthritis at the top of page 15. Pain control is important. Patient's mobility will improve with the use of assisted devices and physical therapy within 3 weeks. More social activities within 1 month. And I did make a note about pain. These patients are certainly going to have pain after the procedures or after the surgery. And if you're taking care of a patient, and let's say they're prescribed to take Percocet, or they may be on an IV medication. Let's say they're still taking IV morphine. You're taking care of them in the hospital. You gave them their morphine dose, and it's 3 hours later, and their pain level is at an 8. So, of course, you're going to give them their pain medicine again. If it is too soon to give them their pain medicine, then you have to assess them further. Their pain medicine should be lasting for the window of time that it's prescribed. So if it's not, do a neuro check. Look at what's going on with your patient. Are they agitated? Are they restless? How are they feeling otherwise? Do they have a fever? And so if they're having some other kind of problems, you may need to call the surgeon, particularly if it's in the first 12 to 24 hours after their surgery. Okay, implementation and evaluation of rheumatoid arthritis. In the middle of page 15 on your PowerPoint, rest and exercise, instructions for joint protection, applications of heat and cold, safety considerations in regards to applying heat and cold is very important. Of course, you only want to apply that for about 15 minutes out of the hour. Diet, we talked about increased protein is important. Psychosocial care, certainly this is going to be limiting to them. If they're used to getting out and, let's say, going to church or social activities, then that's going to be a consideration that needs to be talked about. All right, gout, middle of page 15. Gout is when uric acid settles into the joints, okay? Gout is sometimes referred to as the rich man's disease because it's associated with eating sardines, Jackie, and shellfish. I love shellfish, eat a lot of shellfish, never had gout, but anyway. They need to avoid aspirin because it's a diuretic and alcohol if they're being treated for gout because you want them to increase fluids in their diet. Also increasing fluids to avoid kidney stones as well. Gout will cause them to have an area that is swollen, red, hot, and painful. Believe it or not, the big toe is the most common site for this to happen. And the sardines, red meats, alcohol, all have high purines or the high protein diet. That's what can cause this. Edema can happen, tightened, reddened skin over the area. Inflamed and edematous joint accompanied by elevated temperature and extreme pain in the joint. And they will have an elevated uric acid level. So that will probably be on your test. They take NSAIDs for 2 to 5 days. There are some medications listed here that they could take also. Nursing management, patient teaching as far as the foods that contain this, diet management, weight control, and restriction of high purine foods, and increased fluid intake is important. Okay, now we came back to osteoporosis in your PowerPoint there on page 16 that we'd already talked about somewhat. And we spoke about yesterday, excessive caffeine is associated with osteoporosis. It is low bone mass. And I made a note, by 2020, 1/2 of Americans over 50 will have osteoporosis. And it is 2020, so here we are. It is associated with height loss, kyphosis, which is the bending or curvature of the upper spine, and compression of the spine. So it can cause osteoporosis, vertebral fracture with the decreased calcium, and your goals are to stop bone density loss, increase bone formation, and prevent fractures. It is more common in women, but estrogen replacement therapy can be initiated. There are some negatives to estrogen replacement therapy, so that has to be considered whether it's beneficial or not. Adequate dietary and supplemental calcium and vitamin D. 800 to 5,000 units of vitamin D a day is recommended for someone with diagnosed osteoporosis. And we talked about weight-bearing exercises previously. Biophosphonates can be given, or parathyroid hormones. We do have to remember that some of these medications for osteoporosis can cause some esophageal injury. So some of these, the patient has to stay upright for a number of hours afterwards. So luckily, some of them are monthly that they take. And a MD needs to prescribe the calcium. I wrote that on these notes because I saw a question somewhere that talked about you're dealing with a patient who has probable osteoporosis. You think more so of a petite Asian lady when you think of osteoporosis. Certainly other women can have it as well, but they are more prone to it. But your doctor needs to prescribe calcium. It's not something that I can just go into a patient's room and say, hey, I need you to take your 5,000 units of calcium a day, okay? That needs to be prescribed by the physician. Paget's disease is more common in men. Number one nursing diagnosis is to manage the pain. Number one symptom is pain, diagnosed by x-ray or 24-hour urine collection or an abnormal serum alkaline phosphatase. So your goal is for pain to be an acceptable level. It is associated with osteosarcoma as a complication of that. Bone tumors. In the middle of page 17 on your PowerPoint, there are benign and malignant bone tumors, or primary and secondary tumors. So someone who has breast cancer certainly can have metastasis to the bone, or it can originate. Osteosarcoma is one of the more common types of bone cancers that does arise in the bone, and it is more common in young people, unfortunately. Hang on, I have some more notes about that. It's more common in boys, I think it is. Let me make sure. Yeah. Boys are twice as likely to be diagnosed with osteosarcoma. It can be prevalent in children and teens. And unfortunately, osteosarcoma metastasizes to the lung within 2 years. So if you have a young person, child, teen that complains of vague pain, for example, we had a nurse that I work with, and her child's name was Ella, and her brother hit her in the arm or something like that. This is how they found out she had this. But she said, she just complained, my arm hurts because brother hit me in the arm, and she kept complaining of that. So finally her mother took her for an x-ray, thinking maybe she had a fracture, and she was diagnosed with osteosarcoma. She survived, but she went through a lot of treatments for that, and luckily did not have any metastasis to the lung. Ewing's sarcoma is the most malignant, and they can also have fever and anemia as a symptom with that. And a bone cancer called a chondrosarcoma is a cancer of cartilage cells. I'm not sure that's in your book, but Okay. And elevated alkaline phosphatase, we already said that. That is a laboratory value that could be elevated with a bone tumor. So let's move on into amputation. Lower limb amputations are related to peripheral vascular disease, diabetes, resulting in gangrene, trauma. It could be a reason for amputation, malignancy, congenital defects, or a military injury could all be causes for amputation. Lower limb are the 80% of amputation. Upper extremity amputations could be brought on by crushing blows, thermal and electric burns, lacerations, vasospastic diseases, malignancy, and infection. Upper extremity amputations can be more life-limiting because of you can learn more so to live without your lower limbs than your upper. Care after accidental amputation. So this slide has to do more so with what if we are in each other's presence and Miss Sunburn cuts off the end of her finger, okay? We hope that doesn't happen. So you need to rinse the detached part enough to remove the visible debris. Wrap the part in a clean, damp cloth, put it in a baggie, seal it, and then immerse that entire baggie into another baggie that has a mixture of water and ice. You're trying not to let the amputated part get wet or freeze. You could also put that baggie in a cooler. Let's say you're out at the lake or something and this happens. You could put the baggie with my amputated finger in a cooler to keep it cooled. Okay, if no ice is available, keep the part cool. Do not expose it to heat. And you want to label it with the person's name, name of the body part. That would be hard to remember if you're all freaked out, but try to remember to do that. Preoperative care, you really need to teach patients about phantom sensations prior to the surgery. But now I'm not talking about when Miss Pam amputated her finger, but if there's an amputation of the leg, so to speak, below the knee or above the knee, obviously above the knee is going to be more traumatic, but talk to them about the fact that it's going to take their brain a while to realize that the limb is not there. So they're still going to have these nerve impulses that are confused and they're trying to travel back to the brain. So gabapentin can actually be given to decrease these phantom sensations. So the brain is essentially retaining memory of the limb being there. Muscle strengthening exercises are very important to do. Think hemorrhage, underline hemorrhage, highlight hemorrhage. When you're thinking of amputation and postoperative care, hemorrhage and edema of the residual limb is important to remember. So elevation for 24 hours, monitoring for excessive bleeding, and watching the dressing associated with it. And that's about all we'll say about that. Patient does have to adjust to a new center of gravity, patient teaching for stump care, applying their bandages or being fitted for their prosthetic, and applying that is important. So rehabilitation is very important. Okay, I'm sorry this has been really long, but I wanted to also include a few notes about musculoskeletal farm. You are going to have a final short video to watch that's called PKZ Musculoskeletal Extra. I'll send it to you in an email. But it is going to be a guest speaker that is going to be talking to you about musculoskeletal farm. So listen to her information. That will be on your exam. Any of your slides where I talk about, dangers associated with NSAIDs, toxicity associated with NSAIDs, because those are great treatments for musculoskeletal disorders. Your chapter 44 that you're going to read through talks about muscle relaxers in use with musculoskeletal disorders. So I am going to send you a study guide, not to worry. I'm kind of up in the air about sending you the PowerPoint associated with it. It may not be that helpful with chapter 44, so I may just send you the study guide. So if you have any questions or concerns, send me a text, send me an email. Thank you for listening to this long 45-minute lecture. Thank you so much.